Perfectly fine.
Welcome everyone to the MyData Health session, which I haven't. So the session is on misinformation, disinformation, maybe data also, and trust in a pandemic. I think that's a very topical discussion today, of course, and I think it's very interesting to see the link between simultaneously disinformation and virus spread, especially for this virus. And I hope to convey that to you in my own presentation. So the session today will be, has been a little bit changed in the order, or I think, or maybe I got confused. So Cassandra is now restarting her Zoom. Hopefully she's joining us soon.
I think she's back.
Okay.
Yes, thank you all.
Can I stop sharing? Yes.
You no, please go ahead. You've got it. Continue.
No, go ahead. Do the introduction, please.
Okay.
I'll stop sharing when it's Sherry's turn.
Sounds good. Okay, so sorry about that. Having some Zoom troubles. Hopefully they don't continue to the session. So we have five different presentations lined up for this evening, and all of them have a thread of COVID, trust, information, and disinformation within the pandemic situation that we're all currently facing. Some of them are practical, some of them are theoretical, and some of them are real takeaways that you can bring into your home and share with your own people. So hopefully there's a little still something for everyone, and please feel free to ask questions in the chat, and there'll be opportunities for questions and answers sessions for each of those presented today. So first we're going to listen from Sherry Chung in the Taiwan, and she'll be giving us an introduction to the conceptualization of the self-help management app they're developing due to COVID. So thank you, Sherry.
Hello everyone. Can you hear me?
Very well. Hi.
Okay.
Hi, Sherry.
Hi everyone. So sorry for I just decided to share the topic yesterday, and thanks Cassandra for arranging the schedule, and also because it's midnight in Taiwan, so I asked Cassandra to put me a little forward. So sorry for the inconvenience. And let me share my screen. Can you see the screen sharing?
Yes, it's loading, okay. But I think it will be there.
Okay.
Yeah.
Okay.
What Taiwan has done. Perfect.
Yes. So I think the first thing I want to go straight is like, so I think everyone they know that Taiwan do a very great job to control the epidemic of coronavirus. And I think maybe all of you are very curious that what Taiwan has done. So I just briefly used the simple page to describe how what Taiwan has done on the control of the epidemic. And so at the first, Taiwan has a very great and very big national health insurance database. So, and every citizen, if you want to go to the hospital, and you must you will have your own national health insurance ID, and the ID is linked to the database. And just after the disease is spreading out, I think just in the early of February, so the government, they link the three very big database in Taiwan. The one is National Health Insurance Database. The second is the Immigration Agency database, and the third is the CDC database. So for now, if you go to the hospital and with your national health ID, the doctor can see all your travel history, and he will know that have you traveled to the area which are affected by the disease or not. Then they can do, if you also have some symptoms, the doctor can tell if you are, maybe you are a candidate or not. And this is the first one. And then I can go to the next page. And the second is the to purchase the medical mask by your personal ID. So, and the citizen, they can use their personal ID to buy a medical mask. And with the personal ID and the national health insurance ID, they can check if you have buy the mask yesterday. So only each citizen can only buy 2 masks in 7 days. And all the local pharmacy, they are connected with Taiwan CDC, and all the medical masks are sold by the all the mask is delivered to the pharmacy by the government. So the price is fixed, and the quantity is also fixed. So everyone, you can only buy 2 masks in 7 days. And also we have 3 levels of the isolation system. I think maybe it's similar with other countries, that we have the first level is the home isolation. It's for the person who have direct contact with the confirmed disease. And if you are the home isolation, you will be assigned a special phone and a SIM card that can track your location history. And you need to stay at home. You cannot go outside. And the second is the home quarantine. It's for the person who have traveled to the area which affected by the virus. And also maybe you have some contact with the potential contact with the confirmed disease. So if you are home quarantine, you also need to stay at home. You cannot go outside. And the chef of the village, he will phone you 3 times a day to check if you are at home, you didn't go out, and he will check. And the third is for a self-health management. A person who's self-health management is that maybe you may belong to the home isolation or home quarantine, but you have doing the test and you are negative. And also, so, or you may, maybe you may in the same area with the person who are home quarantine, and then you can, but you have no symptom, you have no fever, so, and you have no symptom, then you can just do the self-health management. And for the person who need to do the self-health management, you are you can go out to maybe buy food, but there is suggestion that you should avoid to go to the public area, and maybe you should stay at home, but it's not the mandatory. And also for this kind of person, the government has no right to collect your data, collect your location history. So, and that's why I'm using the blue word, because this is what we are going to build. And we want to build an app which can let the person who are under the self-health management, they can record their location, they can record their temperature if they have fever. And also we want the process can follow the MyData regulation, that you keep your own data and the data is only shared if you want to. So this is the concept of our product. So we want the app can do the footprint tracker, and also can follow the MyData regulation. That some so you can see that some warning voice has been starting saying that the policy to check people's location history might become citizen surveillance if we allow the government to collect too much data. And so help MyData Taiwan community, we want to build an app to help citizens under self-health management to check and manage their local data, collect points if they follow the instruction to stay at home, and also maybe allow you to record your body temperature. And all the data is collected in an anonymous way, and no centralized server to save the data. And you can share the data to the government officer if there's a need. So, and here's the mock-up of the first page. And because staying at the phone is sometimes so boring, so we also want to make some fun with the ape. Maybe like if you need to stay home for 14 days, you can like raising a tree or build up a tree or raising a pet. So each day when you log in the app, you can get some little reward and have some little fun. And the app is also has the very simple step, like for the person who need to do the self-health management. So, and the app will pop up a notification 3 times a day. And when the notification pop up, you just take a selfie. And when the selfie is taken, the time and the location will be snapshot. And if the location match your home, and you can get a point of reward. And also the data and the metadata is signed by the app, and we're using the software key of the mobile phone. And what we record is the data is saved locally on the phone. It's not upload to the cloud service. And also the time, longitude, latitude, the software key, the data hash and the time are also saved on the blockchain. And so after the 14 days, if you finish the task, so you can get a trophy. So we will create a beautiful icon for the trophy. And then you can choose a selfie with the trophy. Like you finish the whole 14 days task. And then you can share on the social media to say that, okay, I stayed at home for 14 days and now I'm very healthy. Then you can announce to all your friends if you would like to. And also if there's a need, so you can share the key to the government, so the government officer can check the log of your selfie, and they can check your location. If you go outside to maybe buy a food or meet some friend, then they can check the log of your location, and they will see if they can trace your log if there's a need. And now, and actually it's the timeline. So actually we start this project just yesterday. So we just raised the idea and the day before yesterday, and yesterday we decide we are going to do the project. And today we just has our first project kickoff meeting. And we wish to have the alpha beta in next week, and we want to have the beta data on Android phone in the next week. So I know the schedule is very tight, but all of us are very excited about the project, and we have a lot of friends who want to join this project because this is such an important topic all around the world. And we also want to and also considering to an iPhone user, like I am an iPhone user, we also will release an iOS public beta version. Oh, that's my share. Thank you for everyone. So if anyone has any question or want to discuss?
Sherry, thank you for your talk. This is Chris. I'm wondering, so you mentioned a little while ago, like maybe a couple of weeks ago, that people were really scared about the outbreak, and I'm wondering if things have changed at all. And
sorry, there's a little internet connecting issue. Can you repeat your question again?
Okay, so from what I've seen, I think Taiwan has been really doing really well in keeping the number of cases quite low. And I'm wondering if the public has started feeling a little bit more relieved, given how everyone was really worried a couple of weeks ago.
Yes, because just the I think just the day before yesterday. So in one day we just the confirmed case just raised 28 case. So and the confirmed case are increased to 100, and all most of them have the travel history from Europe, and because before that we haven't have the travel alert for the European country, but I think that's also because in March it's a travel season, and the weather in Europe is very well, so there are a lot of people travel to the European country, and I think that's because after that, I think we just announced that everyone, every foreign coming to the Taiwan, they need to do the home quarantine. Yes, so we do a little, yes, we do a little nervous about the situation now. Yes.
I see. Thank you.
I wanted to say thank you to all of our Asian friends who are up right now. It's very late, middle of the night for you guys. Thanks for being up and explaining to all of us what each of your countries has done.
Thank you.
Yes, thank you.
Thanks for the opportunity.
Very much grateful. Okay, so very wonderful presentation, and we're right on time here. Next,
okay.
we have Chris Lee presenting.
Chris, you're muted. Chris? Hello, Chris. You're muted.
Sorry.
Yeah, hi.
My computer just started freezing, but okay, 1 second. There.
Okay. Yeah, it's late, so maybe everyone tired.
Okay, cool. Hello everyone. My name is Chris. I am with the Korea Hub. I'm going to talk about Korea's approach in 3 different aspects today. So the first one will be about the transparent and useful government policies, which have led to a high level of trust in the government by the civilian population. And that leads to voluntary and proactive civilian participation in the initiatives, which make the initiatives more effective. And finally, I want to kind of make a point on the way that the Corona data has been made open to the public, because this has led to some really interesting apps, as well as a lot of excitement over the data, which is really, really good for the country as we go into the digital world. So first, the government initiatives, if I were to choose 3 key initiatives, I would choose these 3. And the first one is emergency alerts. So emergency alerts were, you can't really opt out of them, right? So what happens is, so one time at 7 a.m., I had 3 alerts going off in a row. And I felt like that was way too much. But then this kind of made me realize that if I were close to someone that had just gotten the virus, it would be very, very, I was pretty sure that I would know about it. So this created a sense of security, I'd say. And then there were restrictions placed on purchasing of face masks. So I'm born in 1981. So that makes me a person that can buy face masks on Monday. And so Monday through Friday is distributed. So if you're born in, if the last digit of the year you're born in is a 1 or a 6, then it's Monday. A 2 or a 7 is Tuesday, and it goes on like that. And then there's a limit of 2 face masks per week. So this resulted in a lot of long lines in front of pharmacies, which is the only place you can purchase the masks, but didn't really see anyone complaining. And I think it was because it was pretty clear that it was fair to everybody that's living in Korea. And finally, the corona data that the government is collecting and gathering, it's opened to the public very fast, very transparently, and without hiding anything. And I think this kind of like let the entire population realize that it's a very, very serious crisis, and everyone kind of like joined in. And I think this kind of led to the data sets becoming very good for use. So, and then of course, the data is always fresh and there's open APIs everywhere. So a lot of innovation has been happening. So these are two examples. The left one is a national organization. And basically they're providing guidelines on how to go about making sure that you can be protected from the virus. And at the city level, you'll see these statistics being provided. And these numbers are updated at least once a day. And it's very clear that the government is working really, really hard to do everything they can to give the citizens everything that the government has. Now, the R0 equals 2.0 is something I brought from Paul Olivier's website. And the 2.0 is kind of like, it's an indicator of how many people will catch the virus if I have the virus. So how many people will catch it from me? And the 0.9 and the 0.8 are from pre-symptomatic and symptomatic people. So these are people who have it. So the general public would contain the pre-symptomatic people, I think. And that would mean that the government here is already considering the pre-symptomatic and symptomatic people, which accounts for 1.7. And the significance of this is, to my understanding, that you want it to get below 1 in order to feel certain that it can be contained. And if you can reduce it by 1.7 from 2.0, then that's definitely more than enough. So I just wanted to put this up there for like 5 seconds. And this here for another 5 seconds. And so out of these 6, the one that I've put a box on, I think that one is the contact tracing box. Now, contact tracing is important because it's applied to symptomatic patients, and it identifies pre-symptomatic patients. And so preemptive measures can be taken on the identified pre-symptomatic patients, which will reduce the transmission by a lot. So contact tracing is not only affecting the 40% of the symptomatic patients, but it also has an effect on the pre-symptomatic. So it's actually quite effective.
Sorry, now, it's not 40% of symptomatic patients, it's 40% of symptomatic transmissions, right? By the time people have the symptoms.
Okay, I'm sure you're right. If I explain something wrong, then sorry about that. But so in contact tracing, from the article on Paul Olivier's website, he mentioned something about how contact tracing doesn't necessarily have to be digital. And so this made me think about it, right? Now, on the left here, you'll see that the number of the identifier, so Seoul 282, 281, 280, 279, and this goes all the way down to 1. Right? And here, for each one of these, you can open it, and then you'll get a view of the travel history. But it's not just the travel history that you get. Right? So if you look on the right here, this is the number 2 to number 6 cases. Right? So these were a long time. These happened in January. But there's a link, right? There's a link for number 6, and you can say it says secondary. So this is a person that caught the virus from number 3. And so this sort of stuff is being analyzed by the government, and it's being made public to every day. There are updates. So here, if you look at the primary, secondary, third, fourth, fifth, this is kind of the order in which the virus transmitted. And here is the order in which the patients were confirmed to have it. So the order is, you can see that there's extra information that can be got from doing the contact tracing. Now, in terms of digital contact tracing, I think here, at least I thought of it as local location data oriented. And in terms of location data, because it's a pandemic, there's a law that allows police to obtain the data if they deem it necessary. Now, here, I just wanted I colored these because you see it says sent to an organization, approved, sent and approved, sent, and then they hand it over. And then, so requesting the data, it goes through a lot of government agencies. And what this means is, so if there's a person who says that they don't want to have their location data be known, then the public office that's handling the patient could go to the private sector, but without consent, they need to go to the police. However, the police has no obligation to listen to the public office, so they go above to this is the Korea Centers for Disease Control. And the Korea Centers for Disease Control also does not have the authority to ask the police. So they would escalate the request to the Ministry of Health and Welfare. Now, the Ministry of Health and Welfare will send the request to the National Police Agency. And then the National Police Agency sends the request to local police. And police will ask the private sector for the data. So it kind of like goes like this. And once the police asks the private sector, they'll provide the data back to the police. And then it goes to the public office. So what this means is the forceful measures are not really that significant, right? In most cases, people will give consent. And in fact, what we're about to see is, if we look at this part here, so this is basically what the travel history looks like. And the English here is machine translated, so it's kind of off. But excuse me, if we look at these blue boxes, where it says wear a mask, it actually means that the person was wearing a mask as they moved from, for instance, here, airport railroad to the airport terminal. So they were wearing a mask. So wearing a mask. So this stuff is not obtainable digitally. Right? This is something that had to have been obtained from the patient's personal statement. Now, this person was confirmed to have had the virus. And now that we, like for me, at least when I saw that they were confirmed, and then I saw how many times that the person had been wearing a mask, and how detailed the person had been telling the person who was the government case officer what sort of situation they were in, where they went, and all this. This makes the entire process of tracing contacts much more efficient, because I think at least these instances, the path that this person took, wearing a mask, are probably less likely to have been exposed. So Corona data as open data. So I don't think that I've seen as much data usage in Korea as now. And there's a lot of talk about the self-quarantine app. The self-quarantine app is not really mandatory, right? It's actually something that is there to help the government officials make their jobs easier. So the app itself is a way for a self-quarantine subject to check in with the government. And the person needs to check in twice a day. And if they don't use the app, then they have to call or take a call from the government caseworker, case officer. Now, a person like me, I would rather use the app. Right? So the app definitely has a demand, but it is not a mandatory app, and it's not enforced. Now, that being said, that means it needs to ask for consent to use personal data. And in my case, I'm a foreigner living in Korea because I am not a Korean national. And that means, in my case, I need to hand over my passport number. Right? And the government already has my passport number, so I mean, maybe it's not a big issue. But on the other hand, it does kind of feel like maybe it's not the best option for me. So here are some apps that you'll be able to find regarding all of these are about Corona, and some of them are like, I think the ones with the straight lines, these are kind of the ones that are tracking the location or the travel history of patients, and all this data is available on the web, and it's usually in text forms, right? So they need to do some sort of analysis and some data processing in order to create these, but it's being done, and it's being done by a lot of people, and these apps are coming out like every day, and a lot of them are really, really useful. Like, for instance, like face masks were impossible to find, but then there were apps that would let you know how many masks are left at certain pharmacies. And so, like, this is kind of like it's really creating a vibrant app using ecosystem. And these kids, I didn't know about these guys until today. And when I saw it, it would just kind of like, I was so happy, because I think this is kind of like what I really, really wanted. Right? Making an app should be easy, even for middle schoolers to do. And these guys have made a huge difference. Like they had 1 million users in 15 days. And they started it as a hobby. They did it because they saw that people needed face masks, and they said that they would do it, and they did it. And this sort of stuff is really, really encouraging. And I wanted to share this with you guys. And here is something where the text that you saw earlier, it's put into a table form. And this person is not so tech savvy. I already know, because these tables were posted as images, right? So, but the person he's sharing the information, and he's making it available for anyone who visits his website, right? So this sort of stuff, I think, is like the kind of teamwork, the kind of the community that's being formed. and the stuff that's being learned, I think it's actually maybe one of the reasons why, at least for me, I have a positive outlook on the days to come.
1 minute, Chris.
So that was actually my last slide, but I think I'll take that last minute to talk about this website here. Now, you might feel like these websites that provide information on Corona would be in Korean, but most of them are not. Like even those kids, like I went to their website, they have an option for English, right? And the coronaboard.kr was where I got the location data, the pure text data. And I feel like it's actually something that could be very useful for the people here today. So with that, I will end my talk. Thank you for listening.
Thank you very much for your presentation, Chris. Unfortunately, we don't have time to discuss what you presented to us. We're going to jump right into Paul Oliver DeHay, but maybe during the break we can have some room for a little bit of a discussion because you did share a lot of very interesting and insightful information. So
sure, absolutely.
Please stick around if you do have a question. Oh, glad to hear the connection has improved. I'm sorry about the bad audio before. All right, so Paul, please take it away.
Yeah, thank you, Chris. Thank you. That was very helpful, I think, in helping communicate what worked elsewhere. So I want to present and to enter full screen. Is this good? Anyone? Yep. Okay, so just a quick introduction about myself. So I am a mathematician. I live in Geneva. I'm on the board of MyData Global. I'm also the director of a nonprofit focused on personal data, making personal data accessible and collectively useful. I've been very focused on disinformation, which is of course also the topic of this session in the context of the Cambridge Analytica scandal. And I think there is actually a huge part of the situation with COVID that's very similar to the situation with disinformation. So this is a really, really good session to be in and to participate in. And so the talk has been prepared in part with Ian and Michele Eloy, whom I will introduce in a minute. So to understand COVID, it's crucial to understand some parameters. Chris started mentioning them. So this R0 is the coefficient of multiplication, if you want, of the virus. It's on average how many people get infected from one infected person. And that coefficient is above 1, it's 2, and that's why there is an exponential growth in the number of people affected by the virus. The very interesting element in this virus is that there is, you can see 2 parameters here. You can see the R0, which is the area under the whole curve, all the different colors. And you can see also what's called the serial delay or something like this for the vaccine, which is around 5 days. So it's the average for the next person to start infecting. From the time you start infecting to the next, there's an average of 5 days. And you can also see different parts here. We can also see this RP, which is 0.9, which is the number of infections that are pre-symptomatic, and RS, which is the number of infections that are symptomatic, and you are at 0.8. This is according to the best models we have at the moment. So that means that if you have to get this R below 1, you have to basically start playing a game where you're able to work back in time. As Chris just explained, you have to be able to, from the symptomatic patients, go back in time and find the pre-symptomatic patients. And go back in time, find people who might have been infected, then isolate them in quarantine because they might start infecting others in a pre-symptomatic way. So in a sense, it's a bit like fact checking, because if you spread this information on social networks, people might not necessarily believe it. You share it, you share it, you share it, and then you have to catch up with the mistake of sharing it, of sharing that information. You have to do some kind of fact checking on the information that has been shared, and you have to catch up with the viral aspect of the disinformation. So one solution that was also mentioned by Chris is this contact tracing idea, is the fact that on one day you might have someone who is traveling without symptoms, but potentially has infected people who will themselves become infectious. And so what you do is the moment they wake up on day 2 with a fever, that person reports that they have symptoms, they request a home test, the test is done, they are declared positive, and there is an instant signal to go back to the previous days, who they have interacted with, and to quarantine those people immediately, and or self-isolate, and then immediately test them to figure out who might have the virus. So this is, from a biological standpoint, it's an absolute necessity to do this, it seems, from the epidemiological parameters, to be able to kill the disease without killing too many humans. And short of taking complete self-isolation measures for a very, very long time. And this leads to the situation we're in now in Europe. We're in this hammer section where we're not just, or in most European countries, we're in the hammer section. In Switzerland, we're somewhere between mitigation and hammer. We're trying through social distancing and self-isolation to reduce the number of people who have the virus. We're trying to go down, and we are trying to understand better how different measures affect the virus. But the virus will not go away; it will stay for a while. And the hope is that we can have with contact tracing, we can trace very, very carefully who has the virus, and then go back in time and prevent those people who infected them, who were in contact with them the day before, to infect other people. So we can reduce the virality of the virus from contact tracing. But this, so we have a different set of measures that can be used to do this. You can read them. We can do contact tracing. It's somewhere in the middle. We can do very aggressive testing, hand washing. This is just a fake graph. The numbers are not correct. It's just to give an idea. But the idea is that through different measures, we might get to R below 1, right? And of course, each of those measures have a real impact on the life of people, on the economy, on many, many different aspects. So the question is how to dance. How do we use the measures that are on the left to affect what is on the right, the probability of transmission in a pre-symptomatic way and in a symptomatic way? And if you think about that, there are very many dimensions to this problem. If you forbid people to sending their kids to school, then you will not see transmission among kids or less. And but of course, it will be harder for people to work and to maintain a normal life. You will have to somehow take care of their kids, etc., etc. If you prevent people from going to work, they might do remote work, but not everyone can. And within this context, you always have different families that are where the situation is complex because there is someone working at a hospital that has a high risk of becoming infectious, and kids that might have a high risk of transmitting the disease to each other for a while without anyone noticing, and situations like that. So this problem of reducing the R1 really, the R to 1, really has an epidemiological impact, but also an individual impact. And the two are blended very, very tightly together. You have to go down essentially to within households to understand what the impact of each measure is. Right, and this will matter very much in this phase, which we're hoping to enter in soon in European countries. So the message from viral tracing, the fact that this has been studied, and it seems like with contact tracing, with perfect contact tracing, we can go down to below 1, R equals 1. That message is a message of hope. It seems to be that if we construct enough kits, if we have enough apps, if we have enough people who use it, under consent. We only need something like 20%. And we force people, or we encourage very strongly people who have been in contact to go into quarantine. The numbers seem to show that we can engineer ourselves out of this. But there are deep, deep ethical questions around all of that. And Chris has started touching on some of them. There are legal and ethical questions. And of course, some people in the chat have started also asking them. So the idea is to bring here the professionals. So I want to introduce a friend of mine. His name is no longer here. Okay, so I'll repeat it a few times. I don't know why his name is not there. Michele Loi, he's a member of MyData. He has contributed to the guidance for managing ethical issues in infectious disease outbreaks for the World Health Organization. And as I mentioned earlier, these guidelines say, among other things, that individuals have an obligation to contribute to surveillance when reliable, valid, complete data sets are required and relevant protection is in place. Under these circumstances, informed consent is not ethically required. So what is happening now in European countries is that many governments are starting to apply these guidelines. They're starting to collect data from companies, mostly aggregate data at the moment, and they are starting to use that to inform their policy making. So in a sense, your personal data collected by a telco has been repurposed for this purpose of fighting the epidemic, in accordance with those guidelines, these ethical guidelines, but also in accordance with the GDPR or the Swiss law and so on. But the interesting question is what happens if alongside these guidelines, which can forcibly make people share data, make organizations share data, what if alongside we try to see what we can collect that can be useful using consent? And a secondary question is, what if we do a crowdsourcing effort around this? It seems to be that in Switzerland, this is actually becoming official policy, partly. So to me, that invites a new type of data framework, which I'm trying to get people to rally to and to construct. The idea would be to have a data commons, or several actually, all the way to the level of a small community that would ensure legal compliance. So for instance, GDPR, although GDPR does not apply here in Switzerland, but it could be GDPR plus, so that we can ensure compliance with many different laws. It would follow those ethical guidelines from the WHO. And for those who have the original slides, this is a link where you can see these detailed, what it would mean concretely in these circumstances, or at least more concretely. These data commons would have an eye on standards, would not seek to set standards, but would be very, very much looking at what standards are being used, and of course, try to avoid proprietary solutions or proprietary APIs, to try to encourage this ecosystem of innovation that Chris mentioned. And maybe the most important feature is that it would be time-bound. It would be very, very restricted in the use of data to the context of this epidemic. This would be done in relation with the International Geneva. I think that is really important because we have not a responsibility not just to try to make things better for our own country, but also to think about other countries that don't have the infrastructure, don't have the resources to develop this. And some of them are actually very close to us and also under GDPR for those who have this in mind. On the left, you can see this whole MyData ecosystem, which is what I hope can emerge, and what Chris hinted at, this ecosystem of innovation around APIs, all operating under consent, to which we could encourage the industry to subscribe, and we could encourage the development of hackathons, why not around the world, with, of course, an eye on translation. And to the right, what would happen? Well, this information would be shared, some of it, under consent or under agreements that would have to be decided by the individuals or consented to by the individuals with the government. The information could also flow the other way. And we could get very creative if time allows, and if different entities are willing to follow along those lines, with doing very creative data sharing or data exploitation that doesn't involve sharing between government and these data commons. So we could do, for instance, homomorphic encryption and compute similarity between GPS traces collected on one side, where on the government side, where there is patient data, people who were actually infected, and on the left, where there is there is healthy or presumably healthy patients. So if this is interesting to you, you can definitely join all of us, I guess, on the MyData Slack channel Corona Data, and myself am reachable at those Twitter usernames. So just to be clear, what I'm proposing here is to be a clearinghouse with quotes around legal and ethical issues, and to at the same time work very closely with technical implementers in the MyData community to ensure a very rich, global, effective, consent-based ecosystem of apps to support fighting COVID. Thank you.
Thank you, Paul. That was a very interesting presentation. Does anyone have any questions that they would like to have answered or bring up a discussion point?
A quick question, might be a silly one, but what is the ION standard? I searched for it. I couldn't find anything in the quick search I did.
ION standard?
The ION standard. Okay.
Oh, sorry. So yeah, right. Okay. So out of Finland and Citra, there is something called IHAN with a letter I. So I wasn't referring to that. I was just saying that to keep an eye on the standards that are being used. Okay. Not to use data that is locked into proprietary solutions too much, or because that's necessary in order to foster this ecosystem of innovation that you were yourself it was Chris asking, right? That Chris
Yes.
was asking, was mentioning.
Mm-hmm.
And now would also be the time if anyone had a question for Chris as well. We have a few extra minutes here before we take a quick break. So feel free to speak up and come on chat if you don't want to type it out.
I have a quick question for Chris. Did I understand correctly that there are so many apps now that actually broadcast individuals' data, like their location or their disease status? Did I understand that correctly?
So the people with the disease are the ones that have been documented. So they're quarantined right now, right? And their location is being monitored by the government. But the travel history of the patients before they were confirmed, that is open to the public, and so that data is being used to create a sort of a map where so the locations that the patients had visited, for instance, need to be contacted, and that has a disruptive effect on their business, but it's something that I think society as a whole feels that is necessary. And so to answer your question, the stuff that's in the apps are usually newly confirmed cases, because once a case pops up on the public website, then that would become it would become a new point on these maps. And also they have maps for the locations of Shincheonji Church, as well as they have locations pinpointed around Seoul, at least, of the places where they have did the decontamination spraying. Right, so these are called clean zones. So this sort of data is available through the government, and it's all open to the public through APIs, and that's the stuff that you'll see in these apps.
Thank you for the clarification. Thanks.
Sure.
Can you also clarify, Chris, that there were people who were shamed, right, because of the fact maybe
right.
that they had corona, or maybe of how they got it.
Right, and as a matter of fact, it also had to do with their travel history as well. So some of these people were found to to have spent a lot of time in like near a motel, for instance, and so when that was made public, there were a lot of kind of like how to say mean comments that were posted, and so the issue of protecting the individual's privacy became it's become more important over the last few days, and now I think they're making a little bit they're being a little bit more careful to make sure that the identity of the persons cannot be backtracked through the data that they make public. But I mean, even aside from that, there are a lot of issues actually. So in terms of government, the government in charge right now is on the good side of people at the moment. But just like 2-3 weeks ago, it was completely the opposite, right? So right now it's a good time for the government because it looks like things have been working. But then when the first outbreak happened, there was a lot of complaint from almost everyone, at least people that I know, right? So the situation of trust between the civilians and the government, I feel, is very delicate. And there are a lot of other issues as well. So economic damage is definitely there, especially travel agencies, stuff like that. But at least in terms of the virus, it does seem like things have kind of calmed down.
So I had a discussion with Michele earlier, and he says that it's very common that public health interventions that are done in a forced way are very badly perceived by the populations and turn out to be counterproductive. So most governments know this and don't want to do it. So they also have to adapt themselves, or most Western governments. So they have to adapt themselves to their local culture, which means very different ways of implementing things that in the end have the same functionality.
Right. Maybe I should mention here that patient number 31, there was a lot of talk about patient number 31, like where patient number 31 had contracted the disease. And then when that person went around without abiding by the quarantine rules and things got really, really bad, I think that kind of struck a chord with the Korean population, that what the government was saying and insisting was not something to be taken lightly. So it might have had to do with kind of like that initial mistake that was made, that kind of got everyone to work together. But I don't know if that can be constructed in a safer way for other countries. Just a thought.
Okay, so is there anyone else who would like to raise a point or a question?
Actually, I maybe another quick question to Paul. So for the hackathon, what kind of hackathon were you thinking about? And if you were to do it, then when would be the best time to have it?
Right. So to clarify on the idea, one of the ideas would be that this would be the perfect circumstance to have a global MyData hackathon in building such apps, and make them just very technical, just figuring out the technical elements and not figuring out the legal and ethical elements, because those are very culture specific. so my thinking driving this is that you need to have enough people of the population using those apps for them to be effective. You need to have the apps constructed. You need to have the tech people to have constructed them. This takes a lot of time in responding to the norm, the progressive understanding by people of the situation. And so this is something where MyData can react very quickly by being ready with a global response. And so I would say I don't have the time to do it because I'm focusing on other parts. But if the hub network could work on this, I would say as soon as possible. See what kind of apps have been useful in different countries, work on protocols and standards, and make it happen.
If I could make a suggestion, I think a hackathon is a fabulous idea. But the point you made about the 2 kids in Korea is absolutely essential, in that if we expect a network effect from both the developers and the users, the citizens, there has to be a source of data that is provided to them. Asking questions or worrying about standards, if it doesn't directly, or policies, if it doesn't directly result in apps that provide data and good data to people, it won't take off.
But if we say we're organizing a global hackathon and reach out to epidemiologists, public health authorities, and all of this, we can actually achieve something. We can get their input as well. It's a chicken and egg. If people say it's not possible or we need data, then there is no developer. And if there is no developer, there is no one listening and saying, here, we have data that needs to be analyzed.
I'm all for doing the hackathon tomorrow on whatever basis. I was just, this wasn't a criticism on my part. I was just saying, well, what I said. Sorry if I didn't mean to.
No. So sorry if I responded too harshly. I mean, how to say, this virus really plays on time. There's this time element. The pre-symptomatic effect is really important. So we need to respond to it by also having this mentality of like, let's build something and let's figure out what data we need as we go, right? And because this is the way to get a faster response. Let's make sure the whole architecture is in line with our ethical standards or vision or declaration, all of those things. But which data we'll need to collect, and maybe I didn't insist on this enough, which data we'll need to collect will also change over time. It will be very changing over time. Depending on what closures occur, the way the virus spreads changes. In which population, the likelihood of each of us to be infected changes over time. So this will have to be a very responsive cycle.
I think at least the data from Korea, it seems ready to be used by anyone in the world. And like I said, these websites are the ones that show the data usually have English options on their on their sites as well. So I feel like it wouldn't be too hard for anyone in the world to actually access them. So I guess what I'm saying is the data that exists in Korea is I think you can consider it to be available for the hackathon if it helps.
Another thing is that some big organizations like schema.org have already come out with some schemas for notification of events around COVID. So we could just align to that.
That sounds interesting as well, yeah. So and when you mentioned that time is a critical factor, does that mean that things will, like the sooner we act, the better? Or is there like a certain
I
time?
think so. I think so. My observation right now is that the focus is on handling the peak medical treatment in hospitals, dealing with this, distributing masks, for the very medicalized environment. But there are lots of people at home who are sick, and there will be more soon, who are not sick enough to go to the hospital. All of this situation, they can already start using tools, digital tools, to gain a better understanding of the disease themselves, to start engaging in contact tracing, which will be useful further down, to do all of those things. But I agree absolutely with the comment by, I think it was Adam, that we need to talk on the other side to governments and to authorities to understand exactly what is the best way to communicate with the individuals.
Those are all very good points, and especially the time sensitivity that we're all sort of facing. So I hope there'll be more information available in Slack about this hackathon coming up. Will there be, Paul?
Is there a hackathon coming up? I mean, do other people want to help?
Well, it sounds to me like this is the start of what should be a hackathon coming up.
Yeah, I think we should do it. I've never done a hackathon, but whatever needs to be done, yeah, I'm absolutely going to do it. I have time.
Thank you. Thank you.
And I'm in Sweden, and we have already some hackathons coming up around this, actually, and some competitions. I think also the European Commission is also pushing out kind of a not a hackathon per se, but I think they're just kind of putting out a call for digital technologies. So there are stuff already going on. Yeah. So maybe latching into that or putting that on the Slack channel could be helpful.
The problem with the way it's developed right now,
I think Slack is not open enough. What I've seen work, though, I think we should use Slack. People, for instance, working on ventilators around the world, basically create a Google Doc, and they try to curate that as part, not necessarily of a hackathon. So I would suggest if we want to, if the goal is a hackathon around this, a Google Doc should be developed. Somebody should own it.
The thing with the ventilator, it's very specific. There's not enough ventilators, so let's fix that. The question that was posed, I mean, it's all about defining the problem. When it comes to this specific one about the cutting off the, I mean, how do we help social isolation? At least the Swedish Public Health Agency would say it's all about communication and reaching out to the population. That's what they're saying. But I think there has to be kind of a narrowing down on the grand challenge and the problem definition, and maybe breaking it down to manageable chunks. Or then just keeping it open, I guess that could help too, but I don't know. That's just some reflections.
Well, I think we're saying that we want to do both, right? We want to use the Slack channel for the reflection and optimizations, but we want to be inviting of everybody, whether they're on the Slack channel or not, by keeping the minutes or not just the minutes, I mean by keeping a very clean and communicative Google Doc.
Okay.
Well, this sounds very actionable, and let's take our conversation to Slack and see where we can kind of push from there for a concrete action that we can take. But for now, what we can do is take a short break before our last two presentations. So let's get up and stretch from our computers and come back at 15 after. So take 2 minutes, and we'll continue the discussion on disinformation and misinformation. So thank you for your presentation, Paul, and everyone for participating in the interesting discussion. So 2 minutes. Okay, welcome back, everyone. That was a very quick break, but hopefully you managed to stretch out your leg muscles. So for now, I'll be giving a presentation, and my presentation is on the pandemic of disinformation and to keep calm and don't pass panic on. So let's take a look. So a little bit about me. I'm a researcher on health data in Northern Finland at the University of Oulu, and I'm a co-founder of the Health Data Thematic Group, which is how this session sort of came to fruition. We organically do a lot of ad hoc things like this, coming together on topics and finding some way to disseminate them. So, information in the digital age. I think a lot of us have faced the onslaught of a lot of information that we see and hear every day through a lot of different channels, different mediums, social media, public forums, all these sorts of things. And sometimes we get this feeling about the information that we're seeing. Oh, is something...
Try clicking on it.
Is something wrong?
No, go for it.
Okay, so you can see my presentation okay and hear me okay?
Yeah.
Yeah, okay, thank you.
All the way from Tokyo.
All the way from Tokyo. Oh, well, you're champion for staying up so late. I appreciate you being here, Dixon. Continuing on, I think all of us have sort of felt uncertain about the information that we consume. Maybe sometimes we feel skeptical or feel the need to seek out more valid sources when we read about it, or even can discard this information quite easily because we realize it's absolutely insane, such as using the hair dryer to kill the coronavirus by pointing it up your nose and increasing the temperature of your sinuses. I hope everyone here immediately discarded that bit of information. So I would like people to share what they think they've seen about the coronavirus and the online content by going to menti.com and using the code 584221. And we're going to have a collective look at what people think they've seen, what sort of online content. There should be several instances where you can punch in some themes or topics that come to mind. So tell me what you've seen. Okay, I think these are some great answers. So we have masks, some clearing out the supermarkets, videos of people having parties, toilet paper, that's probably one of my personal favorites. A lot of scientific research, that's good. I'm glad people are looking at that. And yes, there are definitely these human factors of how people are feeling stressed and isolated, and the sort of fear that people are feeling. Oh, fantastic. All right, well, let's continue on, and I'll put this word cloud up for dissemination of the presentation later. So of all these things that were sort of mentioned, they're sort of born out of falseness, and intent to harm information. So that is information that's provided to us with either through negligence or through a specific purpose that's typically negative. And these categories of information are called misinformation, which is unintentional and usually has mistakes such as dates or statistics, language translations, or it could be something sarcastic that's misunderstood, such as the Modest Proposal by Jonathan Swift, or it could be misleading content, such as clickbait or fake news. However, malinformation is the deliberate sharing of private information that specifically targets violation of something, such as disclosing information after signing a non-disclosure agreement for personal or corporate benefit, or through malicious distribution, such as revenge porn, or changing the context of the information with the intent to harm the subject and benefit from the distribution of this information. And disinformation is actually falls between the two of these. So it's born out of falseness and correctness with the intent to harm. So disinformation is typically fabricated for content with manipulative purposes in mind. And it's also intentionally created for information to perpetuate conspiracy theories, share about rumors, cause fear, panic, or harm. And it's usually motivated by money, political influence, and causing trouble for the pleasure of it, such as trolling. And most importantly, disinformation is non-accidentally misleading information. And the most synonymous way I could explain this is lying. So what are the contributing factors to disinformation? Well, low digital literacy levels can lead to disinformation. Lack of internet gatekeepers allowing disinformation to be spread, or a lack of policy available for disinformation, or easy information sharing, such as through social media, where disinformation can be shared and will transform very easily into misinformation because someone thinks that they are being helpful by sharing information, but doesn't realize that it is in fact false. But why does it matter? And in a pandemic, our specific context, it matters quite a lot. The disinformation that's being spread can and has shown to create panic, such as the toilet paper incident that I think we've all seen, can cause confusion and is typically negative and potentially harmful for different outcomes, such as our mental health and our physical well-being. Whereas the inaccurate and misleading information from sources such as misinformation and malinformation, with disinformation, we have to learn how to deal with the problem of inaccuracy and intent. And it really depends on what the intentions of the source are. So all of these forms of misinformation and disinformation can affect the information quality being created, and affects the quality of data being treated as well, by doing things like pushing away individuals from seeking authentic sources, or preventing individuals to seek help, such as through testing for the coronavirus. So people might or people have been seen to not want to go to get tested because they have seen disinformation and misinterpreted it due to digital literacy levels. And here are some of the lovely disinformation sources that I found just from the last couple of days. Of course, we've all seen this toilet paper panic, but more importantly, we're seeing this problem of disinformation in the pandemic all around the world, and there are certain groups of people who are leveraging to take advantage of it by further spreading fear, by aiming to create panic in a country, and forcing countries to respond and use precious resources in a way that they might not have to have previously because of this fear that's being created. So I would like to talk about maybe the more positive side of this. So what can we do when it comes to disinformation? And one of the main things is self-reflection. We can consider the human factors, like the social and the cultural factors of ourselves as people when it comes to disinformation. For example, game theory says that when conceiving in social situations among competitive players, we kind of lose our sense. And so if we see everyone buying seeing panic buying toilet paper, we experienced the result of that, which was you also panic buy, most likely. And if everyone was to buy only what they need, then there will be no shortages, and that will further perpetuate the positive factors of game theory, where you don't see other people panicking and you yourself then don't feel or think that you need to panic and buy toilet paper. We can also look for transparency mechanisms in online data sources. So things that in all the information that we receive, we should be mindful to be critical of what information is out there and reflect on how we can make sure the source of information is being authenticated or providing us with non-disinformation. So this is the coronavirus global cases from the Johns Hopkins University. And one of the transparency mechanisms that they have here is the source of data that they use for populating this map. So we can see information about what's happening with the coronavirus and the specific countries, what's happening because of it. So that's a good example of a transparency mechanism. Burin has more expertise on this, so she'll be providing more information after me. But this is just to touch on something concrete with the COVID virus. So what are some actions that we can take in light of the social and the mental health? I think Vivi set a very good example yesterday by asking us all to reach out to someone who might be socially isolated and checking in on them and making sure that they're doing okay, that things, checking on your friend's mental health and well-being during this time, during such uncertain times, is very important, and that's something that's all within our power to do. So that is a concrete action that somebody could take. And we've all heard about this physical distancing, maybe not, we shouldn't call it social distancing. We should physically be distant from one another. We should prepare and care. Don't scare people. Try to think about the panic that ensues when actions that you take based on disinformation. And if I can give only one takeaway from this presentation and from this overall thoughts about disinformation is to not panic. Don't spread disinformation, and prevent the spread of misinformation by informing yourself, critically analyzing information, and taking in educational factors from experts such as Burin, who's presenting next. So here I have this nice quote from Dr. Cornelia Griggs, who thinks that who has written into the New York Times that the coronavirus is a desperate time and is a public health crisis. But what we need to do is to follow all of our own expertises to help sustain our community. And for us, our role is using our expertise in data. And I ask those who have different expertises to be willing to share their experience and be open to learning from other experts. And I think that the MyData community is a great example of including a very wide variety of experts brought into a shared vision and the collective table. So let's all work together on not spreading the panic and supporting positive actions such as checking on your friends, and let's try prevent the spread of disinformation. So that's all for me. I see I'm slightly over time here, so we're going to be passing off to Barin Sardar now. Yes, caremongering was the hashtag. Thank you. So Barin, if you could share your screen and you can kind of give people the actionable responses that you have ready for misinformation.
Thank you, Cassandra. So I hope everybody can now see my screen.
Yes.
Yes.
Okay.
No problem.
Good. So thank you. It's a pleasure to be able to talk with you guys, especially I think that's the one good thing, to have a conversation at the same time from different parts of the world. So good morning, good evening, good night. By training, I'm a medical doctor. I have done my PhD in environmental health, occupational health, and I worked in academia many years doing research in public health. I recently started Cloud Privacy Labs, focusing on personal data privacy. And we have Consent Grid, which is a contextual consent management and consent governed data flow. And here are my contact information, Twitter and email. These are difficult times, stressful times. And when we are overwhelmed with a lot of information coming from all different areas, especially from internet and different sources, as people, public, we tend to develop our opinions based on things that appeal to our emotion or personal beliefs rather than objective facts. And I think we have seen this, especially with this pandemic. The image here from the Dean Koon's book, you may have seen this before, this has circulated widely. This was, even before it became a pandemic, it was claimed that Dean Koon predicted this pandemic in his 1981 novel because it was a virus created in a lab, created in China, and distributed to the world. It was man-made, and a lot of people shared this wildly. And as it was shared, things were added, like that it was a pandemic in 2020. And I have seen even medical professionals looking at this and saying, oh, maybe this is right, maybe this is evidence. And no, it's not evidence, it's just being widely shared, and we just tend to believe in, and then we kind of lose all rational reasoning. It turns out, if you look carefully, the only thing common is the Wuhan 400. So this is a fictional book. Similarly, there was some person who advocated high levels of vitamin use, and there was a Facebook post saying if you use immediate widespread application of high doses of vitamin C, we could actually stop or slow this pandemic. Again, this is not correct. Even vitamin C efficiency in some other viral diseases has not been proven. But people accepted, digested that, and started sharing it widely. So it's a pandemic by itself. The misinformation is also a pandemic. And a think tank, Center for Strategic International Studies, describes the way information spreads across online networks is very similar, in fact, how a disease pathogen is spreading across people-to-people networks. So how we look at a pandemic of a disease, we should also look at the disinformation or misinformation pandemic similarly, and a resilient information system should be modeled like a resilient health system. So what do we need to do? Actually, there are similar things. Education, like Cassandra mentioned, increasing literacy, awareness that there are some misinformation, some misguided false informations out there. And then there are hotspots, like similar to a pandemic where there are hotspots, where there are people who communicate the virus and it expands from those locations. It's similar. There are insulated online communities that are closed, that are similar in beliefs and ideas, and they don't really get exposed to other ideas. So we have to identify, especially since we are in a social media era, we have to also find influencers and impact, maybe influence them. So an example, a dentist in Connecticut decided to have dental appointments in back to school checklists. And what she did, instead of announcing or sharing this herself, she identified a mom who was in a mom group, and she was the leader, the moderator, the vocal person in that group, and she made her share it to actually get this message out to people who are following her. And then new technology, like we have mentioned here, people have presented hackathons and finding new technology to also fight with the misinformation, AI to find deep fakes or fake accounts and identify them. Of course, like in a pandemic, it's an international spread, so we need international coalition to prevent the spread of misinformation. So this is unfortunately not like the established scientific review procedure in science. When somebody does a research, they do an experiment, they write their results, and then the group or the author sends this to a journal. The editor looks at the publication and then identifies experts in the field, sends the publication to the experts. They read it carefully, return with comments, maybe suggests changes. Then the editor looks at them back and then sends back to the author. And the author, depending how the comments are, revises, changes, does it again, or maybe gives up, but then sends back. So this cycle is repeated several times. And then once the reviewers, the editor is satisfied, and the editor makes the decision, okay, we're going to publish it. And then it's a peer-reviewed publication. This is a very rigid procedure. It's reliable because it undergoes scrutiny, but it's a very slow procedure. And over time, it's some other groups may repeat the study. So if they find similar results, it's confirmed for repeatability. Now, in a pandemic situation, this doesn't work like that. We cannot rely on that slow process. And then obviously there is junk science. It's fraudulent research methods. Like Cassandra mentioned, this can be intentional. It's fraudulent manipulated data or some conclusions that should not be made based on the research. It can be purposefully introduced by certain groups. They may be omitting certain existing scientific results or studies. Usually it's not reviewed by experts in the field. The sources are not well documented. And you can find this anywhere, most commonly online, internet, websites, Facebook groups. You can find this information easily. But it doesn't mean it doesn't exist in reputable, peer-reviewed areas. I'll give you here an example. This is a very famous example. It was the 1998 autism vaccine paper published by Wakefield in Lancet, which is a very reputable medical journal. It took them 12 years to realize and retract this article, but today we are still seeing the effects of this one paper. In 2014, we had a measles epidemic in the US, and it was partly tracked back to this one paper because people are concerned that they don't want to vaccinate their children. So even though it was retracted, the effects are still ongoing. So in a pandemic situation, especially when peer review science is so slow and it waits to be confirmed, what are we relying on? News media, journalism. There are, of course, different types of news organizations, and then there are the ones that are more reliable. Those are the ones that subscribe to journalism principles. They have these common accuracy, independency, being fair, not harm anybody, accountability type of principles. They have either their own code of ethics or they subscribe to common journalism code of ethics. And if an author does something wrong, knowingly plagiarizes or publishes misinformation, there's consequences. The person either is fired or there are some other consequences. So they don't get away with this. And then there's an editorial review process. Sources are cited. You know who is writing this. they have objective verification methods. So the news media may not be, or the person writing may not be objective, but the methods they are using is objective and open, and you can look at it. So there are like different sides of the story. So for COVID coverage, fortunately, many of the reputable, established news media organizations have made their coverage freely available, even though regular access requires a paywall. New York Times, Washington Post, others, some scientific journals, Elsevier, Springer publications. So the coverage related to this pandemic is free and people can access. Of course, regular people, layman, what do they do? It's many times we are bombarded with social media. It's the age of social media. And we see a lot of different things. And nobody is immune to that. Even medical professionals, doctors are not immune to the information. They can be influenced as well. And imagine, again, hotspots, everybody being in a closed community. The other thing, what psychologists call is the negativity bias. Unfortunately, even though we may say we want to see good news, we want to see happy news, that's not really how we are behaving. Bad news gets more attention. We click things that show us bad things happening, or are there visual elements that we can see? If there is some dramatic, surprising elements that trigger our anger or fear, we are actually more likely to click those and share even those. So that's a bias by itself. And then who is the one we have to look at? So who is the one reporting here? What type of website or blog or source is reporting this, publishing this, sharing this? What type of information data are they using? Who are their references? Is there any conflict of interest of what they are advocating? Like the vitamin person who was advocating vitamins. Are there some gains that they are getting out of this information? And what is the mission of the publication? What is the mission of the group that's publishing and sharing? And again, finally, what are the fact-checking sites saying about this? There are many fact-checking sites that I'm going to mention. It's worth looking at their research and see if it's already listed there. And I want to give an example here. Nobody is immune to misinformation or spreading misinformation. So one expert, one doctor, very well intentioned, he wrote an email. He's the expert of coronavirus. He has done the research of this topic years ago and he knows about it. But he's not a public health professional. His mission is not to inform the public. And the pandemic situation is different. The message from one physician, one individual who treats individuals can be different from public health professionals or organizations whose mission is to protect the public health, the general health. So this pathologist wrote an email. You may have seen this actually, it was very viral. He has written an email to his close friends and family and describing that they should use masks, they should use gloves, they should limit contact, they should use zinc. These zinc lozenges, these pastils, in his own lab research, he saw that these are effective, that they stop the virus from replicating. Now, this was his own opinion. So he wrote this to his own friends group, but this was taken out of context. It was shared wildly. I have seen even my medical doctor friends share this as if it was public health message to be distributed to the general public. So the companies that produce these products took it and presented as this was something that supported them, that these zincs are the silver bullet. So it was wrong because it also conflicted with the message that the public health agencies were trying to get out, with the masks especially. But at the same time, it was giving wrong, false hopes to people and maybe making it more dangerous. So there are fact-checking sites. These are nonprofit groups. There are some international groups. Snopes is a commonly known one, Pointer, Full Fact, PolitiFact. And if you look, there's a lot of information. They have actually separate sections for coronavirus. There's so much information out there. Hair dryer, yes, that's one of them. Gargling with water is not effective. Or this is interesting. It was suggested that people should drink something like bleach to prevent. Obviously not correct. More recently, you may see chloroquine. There's a crazy activity around this anti-malaria drug going on right now. And some countries even banned the pharmaceuticals to sell if it especially didn't require prescription because of misinformation. FDA did not approve it. It's not the cure, it's being investigated. But the misinformation within a day or two is spread widely around the world. Now people are stocking on chloroquine, I heard. So this is a dangerous time, and we have to be very careful. Then there are obviously certain organizations whose mission is to promote and protect public health. These are the public health agencies. These are organizations, epidemiologists who work and whose job is to investigate and fight the pandemics and disease. They have the methodology. They are the ones to look at this. And we have, as publics, we have to listen to their messages and not to individuals. So for World Health Organization is number one. They have a site for coronavirus. They give information every day. They have, I think they have a live session right now. CDC in US is another organization. FDA, if you want to look at certain treatments, go to FDA site and confirm it. And then there are universities. There are School of Public Health especially, who are doing this, who are trying to inform the public. So these are the sites we should rely on. These are the sites in a pandemic situation. It's important to have a message, have the same message to go everywhere. With the mask situation, for example, while CDC is trying to communicate to people, not everybody needs to use masks. Please don't use masks. The masks are for, first of all, they don't really work for healthy people. But then individual doctors have been spreading message, oh, use masks, go buy masks because you're gonna protect yourself. So there's conflicting information, and I think it's important to identify the important sources and follow their message, especially if it's a global situation. So finally, what I want to say is that we have to all become, no matter what our background is, we have to all become critical readers, critical reviewers, look at the information very critically. So this also was apparently in a news organization was suggested that if you hold your breath, you can actually identify if you have coronavirus or not. Well, it's not correct, obviously. So that's my presentation. And let me know if you have any questions.
Chris here, I have a question about face masks. So yes. I heard somewhere, unfortunately, I don't remember the source, but I heard that the face masks are more of a way to prevent me from spreading the virus to others around me, rather than protecting me from the virus. And so if that's the case, in my mind, I guess I thought that if everyone wears the masks, then it's kind of it would still work.
The problem here is that we do not have enough masks. I mean, that's the biggest problem. The other problem is it gives a false security to people. Oh, I have a mask, I'm protecting myself. So that's why right now it has to be a logistical decision. If you know you have a problem, you should definitely wear a mask. That's the message. I mean, things may change if we have more masks available, but this is the message that the public health organizations right now distributing. We simply do not have enough masks. My local police organization texted us, local public a few days ago asking for masks for the health personnel, and 95 masks in particular. I think this shows you how difficult the situation is right now. If everybody goes and stocks on masks, there's a false feeling that they are protecting themselves, but at the same time, they're preventing people in front lines who are at the biggest risk to get access to these masks.
Right, yeah. Yes.
Maybe I will jump in here. I mean, when we're on the mask and also misinformation and disinformation, I must say that last Friday I was doing like research and also asking my colleagues, ex-colleagues from all around the world, from the health community about the recommendations and truth about the face masks. And there was really no no agreement and about that. And I think like also this fact that, you know, we are told by WHO and by our health authorities that don't use the masks, while we suspect that the reason for this recommendation is that's what you actually said, there is not enough masks. And I think this is also something that, you know, I think it would be better for trust and transparency to simply say how things are, instead of just like misleading us, because you know, apparently there are two schools. There is Asian school and the rest of the world school when it comes to masks. And I also spoke with my colleague and who is a doctor in Taiwan, and she said, of course, like use the masks. This is, and then when you see all the pictures from China, you know, recovering from the coronavirus, everyone is in the mask. So this is clearly, I mean, this is maybe we're making it bigger than it is, but for me, it's a problem, like, you know, in information. And I have the sense that, oh my God, we if we had masks, we would be all saved. Maybe not, maybe yes, but there is a lot of yeah, a lot of distrust here, and lack of transparency, why we get the recommendations as they are. So I wish here for more like openness and clear recommendations, instead of saying like, yeah, don't use.
Yes, I absolutely agree with you. Transparency would be very important in a pandemic situation. You know, I hear some locations not even telling their public how many cases they have or where they are. So transparency is critical, to be open with all, you know, all the weaknesses and everything we have. But also we have to rely on scientific knowledge, how much, what we know. So currently these recommendations, like if you look at the CDC website, are based on what we know, based on evidence. You have to be separate or distant. You have to distance yourself from these people certain distance, like 6 feet, 1 meter. And if you are sick, first of all, you should definitely isolate, quarantine yourself. But also people who are exposed to you should wear masks, and you should wear your mask. Other than that, if you're a regular person, and it depends on also the community guidelines. I think this is an area where leaders in a community have to make those decisions, and difficult decisions. If you are out walking, you be going to certain places, and how you should be. But I think it's not really a very assuring situation when you know your healthcare personnel doesn't have access to these protective equipments when they need them, but you see people stocking them in their homes or going, you know, out with all these masks and gloves. Again, we need to base everything on science and at the situation what's available. This is a public health crisis, so we have to consider the whole together, not just individuals. Yeah, so that's yeah. Oh, I can't say it this way. I guess.
Well, thank you. That's a pretty interesting information, and I think in the chat we're also seeing some of those thoughts being mirrored. I would maybe like to add that we should also consider the sort of human factors of the masks being worn, the cultural backgrounds. So I know when I've traveled in Asia, it's very common to see someone wearing masks outside of this pandemic context. And whereas in Finland, I don't think I've seen a single person wear a mask publicly. So it's also quite possible that the pictures that we're seeing and the information that we're receiving is being brought out of context to sort of alarm us. Like Carolina was saying, I wish I had a mask, and where can I get a mask? And these are the sorts of things that we kind of want to avoid, or at least self-reflect on, because the frontline people, the primary healthcare professionals, are the ones that absolutely need the masks, and maybe secondary are those who are already sick or are showing symptoms. So if there's a finite source of masks, and I'm a healthy person, maybe I should let those who are more likely to be at risk or who are already exposed to the virus help contain it or prevent the immediate spread of it. We're just about at the end of our 2-hour session. So I'd like to ask if there's any last final questions or comments people would like to bring up.
So yeah, I have a question about the mask situation. So does the mask situation lead to a potential outcome where things get really out of hand because of a lack of masks? And if so, then would manufacturing them be any help?
I guess this is for me, right? So I think not having masks for everybody in the population is not going to increase at this point, because there are other measures like having people stay where they are or not going out are more important, more effective measures. And it's important that we protect the people who are now dealing with this, like healthcare workers mainly, hospitals, first responders. They should have the protective equipment. They are the ones right now. And I think there are efforts to provide more masks for them. But I think as a public, so I agree, every effort should be made increasing protective equipment, especially for those who are fighting this. But right now, we have to also look at what gets the bigger, what's more efficient, like keeping people at homes. Stopping them from going to public places has more effect rather than wearing the mask and going out. So I think we have to have a priority. And I think that's what public agencies are also trying to get out.
I see. So it seems like the biggest concern is that if without the masks, then the people who need to take care of the population might fall sick, which would, and that could really, really be bad.
Yes.
And I kind of confused about, so are masks completely, they cannot be reused?
So I think certain masks they are trying to reuse as much as they can, but certain are not. If you are exposed to a person with the disease, they have certain protocols. It depends on the situation. I think they're trying to do their best. There are different types of masks, obviously. I think someone wrote that. N95, for example, where it's reducing the particulates 95%. So that those are the ones that they're also trying to, even in hospitals, they're trying to identify when to use the most protective masks versus the other masks. Even they are trying to justify to use if they are coming in contact, if they are doing actually an intubation, like if they have an intervention, when they know the exposure will be higher, then they have to choose the most protective equipment. So even they are trying to prioritize what they are using and when.
I see.
Yeah, I have just a couple of thoughts on that, if it's possible, Baron. I know that you're the doctor, but it's also, if you have it survives in the air for three hours. I've seen some research coming from the Research Institute of Sweden, and we also read through some of how long it stays on a certain surface. So it can stay on the surface of the mask, and when you take it off, you get problems there. And the healthcare professionals know how to use masks in a way that they don't get themselves infected, hopefully. So that's some of the aspects that I know that makes it quite inefficient for the general population to use a mask. And I've heard multiple interviews past 2 days from nurses and doctors saying they don't go to work if they don't have masks, because the exposure you get in that situation in a closed environment is, of course, a lot worse than if you'd be in a store queuing in a line, because they're really, really sick, the people they're meeting, while the people in the store might not be as sick.
Exactly, and yes, thank you. So it's same also goes with gloves. Gloves can actually increase your risk of transmitting this if you're not taking care. If you are using your glove there's a sense of false security that you're protecting yourself, but you're touching every surface. You may be touching your face with the mask, especially. You may actually have the virus there. So general public may not really use it correctly. I think that's correct. That's also what I'm hearing.
And washing hands is definitely effective, right? There's a lot of talk about the difference between washing for 10 seconds versus 20 versus 30. Could you say something about that, if you don't mind?
Yes, washing hands for 20 seconds is the recommendation, that you touch every surface, your thumbs especially, you're washing it. It's not like a quick wash, and usually soap is very effective. So you're getting rid of the virus. And also hand sanitizers, alcohol is suggested as if you cannot wash your hands in certain situations. But right now, as you may all know, it's very hard to find them.
Thank you.
Well, I think we've reached a natural sort of stopping point, and a thank you to Bryn for giving us such an interesting presentation, and also to the other presenters. I'm very happy with how this session came together. It was very sort of last minute, and it was kind of all over the place, but I'm very happy with how it turned out, and I hope you all are able to take something away from our discussions and our presentations today. And as Carolina has said, the session is recorded and will be available next week, and we'll also be sharing our presentations on Slack as well. So, and also a big thank you to Vivi and Carolina, who have stayed up extra late for this after putting together the main event, and giving us your energy for an extra 2 hours is so very much appreciated. So maybe no high fives and no hugs, but distant clapping and positive thoughts from me towards you and everyone else here.
And well, thank you, Cassandra, for putting on this session, and everyone for presenting and joining. And as I wrote to Cassandra in a DM, it gives me lots of hope, and I'm sure that we will fight all this together sooner or later, hopefully sooner. And there was a question: where is the next health data meeting, from Temu? I don't know if Cassandra, you have some meeting, call, meetup online scheduled for health data?
I don't actually, but you are not the only person who has asked me, so maybe I'll construct something in the coming week, since time is of the essence in our particular context.
Cool.
I know that's a cruel question to ask when you've just put together this amazing session, but it's just to keep the energy going, as clearly there are people who want to participate. So just a thought to announce something soon.
Yeah.
Well, thank you. It's good to keep the energy going.
Really great. I had to duck out for a while, but great job in pulling this together.
Fantastic.
Thank you very much.
Thank you.